Hey, good morning, Rich. Ready to
Hey, good
go?
morning, Mark.
Let's rock. I think our topic today, we talked about smile design, facial aesthetics, right? We can get into photogrammetry and facial scanning and things that kind of are a mainstay at a sophisticated level
Hmm.
for dentistry that's gotten more and more sophisticated, like uh, some of these organizations that like use Nemotech software and use photogrammetry. I think with an airway focus, we have a little bit of a leg up as to what really it means. That's really the future. And so I thought we would talk about, and I think you had suggested it on modern smile design, and you're someone that's a thought leader that gives courses on this. So with that topic, what are your thoughts about this with an airway focus?
Well, I think it's entirely required today that we incorporate the airway component into smile design. Otherwise, smile design without the underlying function that you get from adequate breathing I think dentistry is going down the wrong path. We get all excited about incisal edge display and the buccal corridor and getting the proper occlusal plane in vertical dimension. We get into the minutia of ratios and teeth and all of these things, and whether we need to create more space by performing IPR or by adding more. And we're getting very, very fussy about the precision of all on X cases, and which is good, particularly as you mentioned, photogrammetry, allowing us to create prostheses that fit better than they've ever fit. But if all of this stuff is being done in a vacuum of the old way of thinking, I think we're missing a great opportunity, an enormous one. I'm very, very concerned about it. It's like, I like you said, Mark, I teach a lot of courses in the area of smile design and execution and occlusal stability and all these beautiful topics that we all must absolutely know how to do right in our restorative practice. That's for sure. No doubt about it. But if I'm looking at a case, for example, today where there's lower anterior crowding and you've got some malaligned teeth, and like one of my participants would bring this case up as a case study to show the rest of the class, and I'm looking at somebody that has obvious anatomical issues that are without a doubt in some way contributing, if not the source of major airway issues. And then they're getting all this nuanced, little fussy little interest in how do we deal with this lower here where I have some crowding. Can I do veneers on these, or do I need to make them do Invisalign or some kind of clear aligner? And I'm going, oh yeah, there's this case is not about that right now. It will be. Okay, let's go in that direction, but at this moment, in the course of this patient's overall health and in doing the best dentistry can, we need to get some other things taken care of first. And I think that this is a huge problem we have right now in dentistry. We're not, uh, how do you say, we're over treating the wrong problem,
Yes.
or maybe we're properly treating the problem that we only see,
Yeah.
and I'd love you to go into more about this because interestingly, this is the thing I found about a proper airway practice. You're not putting aside aesthetics. You're actually putting aesthetics back into the front again, but in a way that we are meant to be in the in the phenotypical approach towards what is our true look supposed to be, and not just a few teeth, but the entire skeletal base. All of the structures can be improved dramatically, and rather than just looking at twisting teeth around and leveling them and aligning them and changing their shade a little bit, maybe their shape, let's look at something much more important. One more thing, because I know you're just ready to go. But yeah, I know you, Mark. But I thought,
You're
but
priming the pump, man.
I know. You're like, woo, I got good information. But the last part was, just think about that case where the finished result shows the black shadows of the buccal corridors in a clearly underexpanded maxilla, and all of the work to create veneers all the way back, sometimes even to the first molars, to fill this out as though this is some great, insight into how we can improve this patient's overall appearance. And I'm just once again banging my head, going, "Oh my gosh, this person doesn't understand." And I want them to understand because I know they'll do beautiful work. I mean, but they're not understanding the obvious. The elephant in the room is not the adding a thicker veneer to the premolars to fill in the space. Let's get things filled in, but let's do it at a little different approach. I saw Jerry Ann. Hi, Jerry Ann.
Yeah, I know. She's
Hey, hey, if you're watching this, just leave it. Leave it. I think that's cute.
no, it has to anyway. Well, so you're an educator, and as am I in this domain, and I always like to think we're talking. How could we make this meaningful to our audience, the provider, the clinician? So I always like to talk in terms of concepts that you can actually apply and how to think about the problem. And I'm not going to try to convince anybody this is the way to do it, but I will ask the provider, the clinician that's listening, to try to maybe think about it differently and answer their own question. And I understand that when they understand the questions to ask, they come to the same conclusions. So I'm going to break this discussion down into a number of different ways of thinking about it. We could even call it a crude algorithm. First of all, let's talk about what we do as providers. There's the diagnosis, and then there's what I call the skill labor or the intervention, which involves treatment planning, and you can have courses just on that. So those are the two main activities that any provider in medicine or dentistry is paid for. It just happens to be that in dentistry, oftentimes the diagnosis is kind of an implied consent that, it's the treatment codes. So it's the treatment codes that really drive the fiduciary that the patient pays for. And an airway focused approach, we kind of flip it more like the medical model where the diagnosis is really the most important thing, and that maybe get less involved with what you could do about it and really understand what the problem is by focusing on what the diagnosis is, because that's also how we're going to measure our outcomes. So, with an airway focused approach, our diagnosis is really going to be based on the medical metrics, the medical comorbidities, not the dental stuff, right? So, how do you leap from the medical diagnosis to dental treatment? So, a patient comes in when you just don't really understand airway focus and you start asking questions about sleep, and the patient's there got a broken molar and saying, "Doc, why are you asking that?" I came in here for this broken molar, all that stuff. When you learn how to connect those dots for the patient yourself, then it becomes much easier to communicate what we're doing and the value to that. That's all for Airway Mini residency. We get into all that, but that's an absolute must. You can't just give lip service to that airway focused diagnosis where the medical indications are what drives it, the fatigue, the snoring, the fragmented sleep, the metabolic dysregulation, the cardiovascular comorbidities, et cetera, et cetera, et cetera. So let's just, for right now, put that aside and assume that we're already talking about intervention that's driven by the medical indications. So I think that's really important because that is really what drives everything we're going to talk about moving forward. So with that said, now we're we're now going to be treating the patient.
Right.
We understand form follows function,
Mm-hmm.
and we understand that with an airway focused approach, the cake, if you will, is addressing the risk factors that are resulting in the symptom profile that the patient presents with. And that's how we're going to talk to our patients, like the fragmented sleep, the snoring, the anxiety, the depression, right?
Right.
The icing on the cake is the aesthetics, say the facial aesthetics, the smile design. Who does not want their cake and to eat it with nice icing? Well, everybody does. And oftentimes the main driver for the patient that comes to your office is the aesthetics because they don't really understand the underlying foundational part of the symptoms that they present with because you're not asking them. But once you start asking them and they realize, wow, you could fix that and that could look better. Oftentimes they start crying, right? We've seen it, right? They go, "Oh my God, all these things I thought it was, something else. The reflux, I'm taking these medications, the allergies, all those things that are being treated by the medical professionals in isolation, all those symptoms. When you start understanding with the airway focus that it has to do with the facial skeleton and what we can do as dental providers, it kind of changes the relationship with the patient, but they also want to have a beautiful smile. So, with that said, I want the provider to think of a couple of concepts. Number one, is the intervention subtractive or is it additive? So, an example, IPR, that's subtractive. You're taking away tooth structure to create space.
Yeah.
Um, the other example would be orthognathics, a three-piece or segmented maxilla is over treating a facial skeleton. Maybe it's not subtractive, but it's over treating a problem that can be treated with less invasiveness, if you will, with a MARPI to make it a one-piece maxilla.
Right.
If in your decompensating of the nasomaxillary complex, you take the time to widen the patient more than you would likely with a three-piece maxilla, less of a recovery issue for the patient, more stable over time. So that is an overtreatment. So are we overtreating a problem or undertreating the right problem? Um, and is it subtractive? So if we're talking about plastic surgery, a facelift is subtractive. So what are they doing is they're subtracting tissue that's wrinkling and they kind of tuck it away, right? They tighten it up and they throw away the tissue that they cut, and now you've got like this tight looking face that looks younger because there are no wrinkles, but that's still subtractive. Or the hump on the nose that's from a clockwise growth pattern that they're having the nose job, not realizing that that hump is because the cartilage is being pulled down and back. So the plastic surgeon or the ENT is removing the one part of the face that actually is in the right place. So those are all a subtractive way of thinking the problem. And in fact, with the all on four, I'm going to say that's subtractive, where you're creating vertical growth by, taking those knife edge ridges and cutting off the top of the ridge to place your implants, and then you're placing the implants. That's actually subtractive as well, and that all concerns me. So
Yeah.
with an airway focus, you can go in the opposite direction and be more additive. So understanding that airway problems are as a result of a facial skeleton that's deficient and likely started during growth and development or over treatment, like extraction retraction, right? So the
Mm-hmm.
extraction and retraction. So let me also, as an aside, say four bicuspid traditional extraction orthodontic case is subtractive. Now, I am not so hard-lined to say that you should never extract bicuspids. So the exception there is I will say that extraction of bicuspids is indicated with an airway focused approach if that results in an additive outcome. In other words, if the bicuspids are in the way of that forward telescopic movement and you're decompensating of upper and lower arches, and that if you extracted the teeth, you could bring the mandible more forward, then that's where the payback is. The facial skeleton is brought more forward at the expense of subtracting some dental structures.
Yeah,
So does that
Mark.
make sense?
It does. Just for the dentist listening, what do you mean by decompensation? Let's
So,
review
so
that.
when you're doing orthodontics, for example, you see high angle, you see a curve of spee, maybe a two plane curve of spee where the incisors over erupted due to
Right.
dental alveolar extrusion, right?
Right.
And the occlusal plane is lower. You've got to level in a line. You have to try to modify that curve of Wilson, curve of Spee to decompensate so that the jaws fit together that are retrusive, that the surgery will actually telescopically move everything forward and maybe with an impaction up, right? So that in order to do that, you someone has to decompensate and get both arches ready for that. And so that's what we call decompensating. Now, you can have these surgical first cases where everything's pretty much there, but they're just bimax retrusive, and you could bring everything forward and then do some refinement afterward. Okay, but that's
Gotcha.
usually the exception. So that's what decompensating is that you get the arches prepared before the orthodontic surgeon does their thing with the facial skeleton. So, having answered that question, I want us to think about what we can do is expand and add more of the facial skeleton. That's the problem that's made the airway smaller. As Donald Enloe would say, the airway is the keystone for the face. And what does he mean by that? As the accepted father of craniofacial growth and development concepts, that wrote Essentials of facial growth. Back in the day, every orthodontist goes through and understands that training. That's a key concept. The airway is the keystone for the face. And remember what a keystone is that part in a Gothic arch or a Roman arch that stabilizes the entire arch and gives it stability. It's that keystone in the arch that when everything comes together, those arches will stand the test of time for hundreds of years. The rest of the building may crumble around it, but it's the stability, it's what stabilizes that arch. Well, for the face, what stabilizes that is the airway because we have to breathe. And so what's happened is our facial skeleton has become smaller. We won't get into the anthropological concepts, but when we understand that we can actually expand the facial skeleton to make the airway bigger, which decreases airflow resistance, patient's going to be healthier. Form also follows function. It also looks better. So when you look at a Paleolithic face, the face phenotype that we were all programmed to become, it's high cheekbones, the zygomatic arch is high and forward, big square jaw, coming forward, more brachycephalic, and a straight profile. That's aesthetic, like the Angelina Jolie kind of face, the Brad Pitt kind of face, that people look for. It's a Paleolithic face. So if you have someone that's got a long face and they're narrow and their teeth are crooked and you don't recognize or have an airway focus, you may have to subtract some structures to get the teeth straight, but they're still in a deficient craniofacial structure. The face just doesn't look right. Facial aesthetics is not about the alignment of the teeth, how straight they are. And yet, that's what a lot of us were trained to do is just get the teeth straight and everything will look better.
Yeah, I wanted to jump in there because I think it's really interesting because in the past I would look at a patient that had obvious vertical maxillary excess, a super gummy smile, and the discussion would mention surgery. This is in the pre-airway mindset. I would mention surgery just quickly to get it out of the way, so I knew, because I just knew the patient was never going to have surgery. That was sort of my
Right.
prejudging approach. So it was always about, well, we could do some crown lengthening, and so this
Yeah.
aesthetic crown lengthening became this popular option, and I can do the procedure really nicely when it's indicated. It's great, but now I have some real tools to discuss.
Yes.
Maybe there will be surgery down your in the future if intrusion plates don't give us the results we want. If things are not, if it's a little too far gone and we have to go that direction, but always being motivated by and being guided by the medical indications for our decisions. But it's a whole deeper discussion now, and it's actually one that I don't have to have. I know eventually that patient is going to see it themselves and they're going to want to have the treatment that gives them the most optimal health. So I can look at a gummy smile today and no longer think, gosh, how am I going to treat this person? I can almost sort of go, this is going to be really fun because I know where this is going, and I almost always know that
Yeah.
what kind of metrics I'm going to receive. I'm going to be able to look at that HRPO report and go, yep, thought so. I'm going to be able to look at all the other factors and go, yep, this is where this case is. This is where it needs to go. I'll ask a history, and they seem to be very similar, kind of historical findings. And now it's interesting, but it gives me hope to help a lot of people that are in the past we didn't have really good answers for. I mean,
Yeah,
there's
you're
a whole
right. I
book
mean,
on treating the gummy smile. There are lectures, there are courses you go to treating the gummy smile, and they've got nothing to do with treating the gummy smile, with really treating the underlying structures. It's all about stuff
yeah,
we
it's
know.
over, you're right. It's over treating the wrong problem. And then the diagnosis is incorrect, right? Because you're not even
Right.
thinking with the gummy smile, you're not even thinking about the questions you're now thinking about that are very powerful motivators for the patient.
Well, yeah, I wanted to stop you there and go, the diagnosis was vertical maxillary excess. And now I know that's not a diagnosis, that's a finding.
Those are just findings. Exactly. It's
Yeah,
also with the Engels classifications. Those are just findings, but we were all trained by the thought leaders, and it's no one's fault. It's just the way we're thinking. You know
right.
what? It's no different in medicine, right? We know
It's true.
we talked about tonsils and adenoids, right? Again, a subtractive surgery that the studies and the evidence actually would say in retrospect that that wasn't the root cause. That was just a symptom that was treated. Same thing with a U triple P. Just make the hole bigger. Very mechanical in our thinking, using a mechanical approach for a physiologic problem. And that's the problem with the airway focused approach. We're looking at a physiologic, looking at the patient physiologically, but the physicians do the same thing.
Yeah, sure.
So it's the way we think about it. Again, going back to ask the question, if it's going to be a subtractive surgery or intervention, is that really the best way? And are there ways of adding and doing the same thing with a better outcome? So that's the way I like to think about it. When you're doing IPR, is it can you actually create that room by adding more bone? Can you, if someone's got grade 3 tonsils, can you actually do something to shrink the tonsils physiologically if you catch it early enough so that you're not having to do that subtractive? If they've got a hump in the nose, can you actually, correct that early on in growth and development when you see the trend? So these are all things that
Hey,
we teach in our courses. And one
yeah,
last thing is you mentioned it.
yeah,
We now have a big toolbox
yes,
of interventions that we could do that we didn't understand before with these protocols. And of course, we give courses in that. But now, no better time to be a dentist to really be treating the patient properly with all the things that we as providers can do that medicine can't really do as effectively because it has to do with the facial skeleton and the structures that we treat every day.
Can I just
Yeah, please,
emphasize one more point you made, and you made it clearly, but I gotta just summarize it again because I
please.
think a lot of people are just your mind can be blown when you really understand this. That a bump in your nose is not the intended phenotype of that face. It wasn't that you got dealt some cards that gave you a bump in your nose because your great grandfather had bumped his nose. There may be a small component to that because we can't deny genetics, but we have to think about the fact that I love the way you put it. It's not the cartilage being the wrong shape because of some inherent cartilage shape problem. It's like that because the face grew down and stretched it. So you get this bump in your nose. I love that. I can't stop seeing bumps and noses now. I'm in the airport. I'm seeing it everywhere and I'm going, oh my God, these are patients that grew this way. It's so pervasive. It's just like it's almost everywhere. And what an incredible realization to know that we as dentists, we can treat this, guys. It's crazy, but this is 100% in our wheelhouse. 100%.
Yeah, I mean, hey,
And
it's just,
the
yeah,
thought of
you're right.
shaving it away in a surgeon's office in Beverly Hills compared to building the face back to where it's supposed to be or to
And
where it was intended to be.
making it a diminutive, really cute nose that actually now has flow limitation, right? And the
You're
patient
actually
feels
making
like,
them worse.
and it's making them worse. So let me just make this clear to our audience too, is, this came from classically from two ENTs that wrote a paper about this called the Musculoskeletal Hypothesis by Stephen Park and Stephen Stupak, two ENTs from the East Coast that wrote the paper about this, reviewing the evidence in sleep medicine recognizing this clockwise growth pattern that manifests with that marker. And they explain it as ENTs that this is a growth pattern issue. It's not a problem to fix because you've got this hump. You just have to understand. And really, what they talk about in there and showing that is also all the high angle phenotypes, the open mouth, interlabial gap to go with that hump on the nose. So it's all these phenotype findings that we, of course, talk about in detail before we do our smile design with an airway focus. So,
Right.
yes, those things we can really get deeply into. So, it's not like, we're these two crazy dentists that are saying, oh, you can, we figured this out. No, it's other people that have written about it, and we're just basically using that as support from our medical colleagues, no different than that recent study that we reviewed about 3 episodes ago from a multidisciplinary, multi-centered study showing that the size of the airway is has a direct correlation to brain function, intelligence, et cetera, et cetera. That they're doing these functional MRIs of the brain and they're looking at cognitive function in adolescence, all having to do with the size of the airway. They didn't get into the fact that that airway is defined by the facial skeleton, but of course we know that. And that's where, when you're looking at smile design, going back to that, for me, I talk to the patient about let's get the face right. So if we get your face looking the way it should, and when you've done enough cases, you can show the difference the before and after. And it's like almost takes your breath away. Go, oh my gosh, they now are looking less at the fact that the teeth are straight with a beautiful arc of smile and no buccal corridors, and more at look at that face, look at that profile. Wow. And then when they understand and listen to the patient's testimonials that they say is, I came in for smile design and these aesthetics, but honestly, after this whole outcome, the thing that I value the most is how I feel.
Hmm.
I'm sleeping better, I'm breathing better, I'm getting along better, my memory's better, I just function better. I'm not gaining the weight that I used to because of all the metabolic issues that come along with, fragmented sleep and airflow. So that in the end, if you communicate and learn how to communicate to the patient that the wellness is really what's driving it, and that all these findings, whether it's a high angle, distalized condyle phenotype, that was retracted, or the hump on the nose, or the narrow palate, when you start talking about, and they understand that those are just findings, that the upstream problems that they're really suffering from, because you're asking the questions, that they're now saying, yeah, why'd you ask me those questions? That's exactly, how'd you know that I have all these symptoms? You mean you could fix that? That's what I want. So now, and I've talked to a number of orthodontists, and a number of them that have gone through the Airway Mini residency, that says it blew their mind, that they now, in good conscience, see the patient very differently. That in the past, they would see the patient coming in, they do the workup, they give the gallery, and they would check the boxes on the orthognathics. They'd say, I know it's an orthognathic case because they've got 3 acres of gumminess, but they don't want to take the time to work them up for the orthognathics, because in their mind, the patient is going to say right away, I'm going to lose the case because I don't want to do surgery.
Right.
Doc, you're overtreating me. I don't want to do surgery, because they don't know how to talk to the patient about it. It's not about the gumminess that you're going to treat. It's about what the gumminess means. And when
Right.
the patient understands, you mean you can get me off my CPAP? It's so, Richard, it's so funny. If you start really seeing the advertisements in dental magazines, for example, um, ironically, there's an orthodontic journal. You'll see some of the sponsored advertisements where you've got this totally VME patient with braces on and a big smile in an orthodontic journal or magazine.
All the
It's
time.
like, oh my gosh, when you really understand, you mean, it's like everything is about how you can get the teeth straight in a very vertical face that will never just quite look the same.
Right.
So the exciting news is, I don't blame anybody, but with an airway focus and understanding the tool chest that we have, we could get that all corrected to look beautiful, but most importantly, healthy and well for the rest of their lives off of CPAP. And so that's the airway focused approach, is really learning how to talk to the patient with the medical indications so that they buy in because they understand. It's much more rewarding from a professional point of view, where you can actually project on a lecture screen, 30-foot tall lecture screen, the history of a patient that had UARS, that you're not just checking the box and saying, no, they don't have an airway problem, and then you do whatever treatment. You actually show, actually, they had upper airway resistance syndrome, they had a high fatigue, they had all these things. And now we treated them, and look at that arc of smile. Look how wide their face is. Look at how we addressed the gumminess with intrusion plates. Look how forward we brought the jaw. And the patient looks amazing. And then those veneers that now that you're doing because you created the space have a very different meaning. They're stunning. It takes your breath away of how beautiful that dental work is, only because the foundation is much more beautiful. The
Yeah.
facial skeleton has been put where it needs to be. And now those white things that we call teeth, now you've got a beautiful canvas to do your art that you could never do if you're just treating the teeth.
And I would also say less chance of chipping of veneers, breaking of
Yeah,
restorations, less chance of instability in the occlusion. Now we're putting things in their proper place physiologically. Airway is going to be compatible and sympathetic with the entire restorative. It's all fitting together properly.
yes,
So, this is aesthetic dentistry, Mark, at the highest level that we
yes,
currently have in our that we know today, the highest level. And I think that we're not in any way undermining or putting down anybody that has put out a whole
no,
course on aesthetics or written a
right.
beautiful book on aesthetics. There's some of the most amazingly just gorgeous looking dentistry that our colleagues have put together and put forth. we're just now saying that's great. All of that still is going to be important, but it's a matter of when. And so it invariably with proper airway management, a lot of the aesthetics will be more minimized. We can be more minimally invasive, quite frankly. We don't have to do bone removal and shaping gingiva. We don't need to open verticals dramatically. We don't need to put big thick veneers on teeth. We don't need to do a lot of the things we thought we had no other choice but to do. It's I listen to some of my mentors in aesthetic dentistry over the years, these brilliant minds, these wonderful people that have really guided me. And you and I both, we've learned so very much from
hundred
these
percent.
leaders. Incredible stuff. And yet now with this extra layer, it changes the game. It allows us to come up with the kind of result that we are always dreaming about. We want aesthetics for life. And I oftentimes use the term in my lectures, aesthetic durability. Aesthetic
Stability, long
durability.
term, another way of saying long term stability, because the organism is functioning the way it was designed to function.
Right.
And you said it, beautiful dentistry. There's nothing wrong with beautiful dentistry, but it's beautiful dentistry having to do with teeth. But you're also missing all the structures that are supporting those teeth that you are, I'm going to argue, oftentimes unwittingly or wittingly over treating the dentition because you don't understand that you can actually and should treat the bone, the dental alveolar complex, and the facial skeleton. And we didn't have a lot of these protocols in the past. And you and I know we've sat in as members of some of these, very prestigious academies, and you're watching these lectures from the thought leaders in the profession at the pinnacle of the profession, and they're going through their case, and you look at it and you are so distracted because they're not even talking about the elephant in the room, this huge Malampati grade 4, this tongue scalloped. They're looking at the teeth all around it and look at the smile and the display and everything. And you know what it means to that patient. And you look at them and but now everyone's kind of waking up. So I think I'm very confident that what the courses are going to be like moving forward using our beautiful technology that we started off talking about photogrammetry and the like is that we're going to be facially driven. And let me say that that's synonymous when you understand airway focused approach, airway focused driven treatment, because the airway is the keystone of the face. So we'll acknowledge that. So when we're facially driving the outcome for our patients that come in, we're going to look at the facial skeleton and the size of the airway to make it bigger and additive versus subtractive. So now you're looking at the face, you're taking a facial scan, you're taking your intraoral scan, your STL, and then you're merging it with your DICOM with our technology to have an outcome in the end through our treatment. We're using those data sets to show what's possible. And at the end, you have a healthier patient. Right now, there are a lot of sophisticated protocols that aren't addressing any of that and still over treating the wrong problem.
So
And I'm not blaming anybody, but when you know really what needs to be done and the tools that we have that are less invasive that the patients will accept, then you're going to look back and go, wow. And I'll just say this, I have an ENT that was in my practice, well-known ENT, was one of the early forefathers from NYU in sleep medicine.
mhm.
And he moved to Orange County and he came to one of my lectures and wanted to go to lunch with me. We went to lunch. This is years ago. And he said, hey, we should work together. And he was kind of retired. And he was facial aesthetics. He did facial aesthetic surgery.
Wow.
Okay. And that was his emphasis as an ENT.
Okay.
And he said one day, he said, Mark, I look back at my own entire career and I just feel really bad understanding that I mutilated so many patients.
Hmm.
And now that I see what really needs to be done, I am very humbled. And he said, what you're teaching, what you're saying is where we in medicine need to go. And that's starting to leak out now. It's starting to come out, no question about it. So this is somebody that it's hard after at the sunset of your career to look back and say, wow, I straightened out a lot of teeth, but I wrecked a lot of faces. That you don't feel bad about it. You did the best that you can, but then that's now move forward from that. This is how we learn. Let's move forward and start really embracing the what's really important as a provider, and that's wellness. Because form follows function. Very likely, if it looks beautiful, it functions well. And so I think that's really the point of this podcast is to understand there are many tools, the medical indications, don't overtreat the wrong problem, understand the tool chest that you have to properly treat and precisely target the right structure, whether it's the skeletal base, the dental alveolar complex, the dentition, the joints. All those need to be treated properly. And we could do that with an airway focused diagnosis and airway focused tool chest. And that's, I think, what you and I in our sunsets of our careers are really excited about because it's more rewarding for the patient. They're now not putting their teeth together. It's not a constricted envelope of function,
Right.
right? It's actually if you have a constricted envelope of function, think how are we going to fix it? It's not by subtracting and having angles, shallow angles of disclusion, and you know, uh, lower cusps, height, and groove direction, all the stuff that we were. Yes, that's a mechanical approach, but if you do have a quote unquote constricted envelope of occlusion, ask yourself, well, what can I do as an additive approach to address that? Because that same patient also very likely, if you're looking, has distalized condyles
Right.
and some temporomandibular disorders. They may be even slated for joint surgery or joint replacement surgery. You actually, what you want to do is unconstrict by expanding, protracting, and you could do that with skeletal expanders now routinely, surgically facilitated orthodontic treatment, clear aligners,
Yep.
Balder plates, intrusion plates, all the things that you could learn about in making the patient healthier, more beautiful, more stable, with then the dentition being treated more conservatively where they're not putting their teeth together and breaking your dentistry.
Right.
So it's
Yeah.
all in the same domain of what we've always wanted to do, but with a different focus that really starts with treating the patient attached to those structures versus honing in right into the structures that are attached to that patient. And that's really what we talk about in the Airway Mini residency, right?
Yeah, it is. And I'd like to say that, if you're listening to this and you're like, okay, okay, it sounds like there's a lot of these procedures that seem pretty sophisticated. Yeah, they are pretty sophisticated, but they're not overly complex. And all of them, with the exception of the MMA, which is the maxillomandibular advancement surgery, where the jaws actually have to be moved forward, all of these procedures can be done in your office. And this is local stuff. This is stuff that we can do. You may need the help of a periodontist. You may initially need the help of one of the airway trained mentors to get you going. But once you're trained, the lion's share of this work can be done in your office. And it's not just about straight teeth. It is about straight teeth, but it's straight teeth with improved function. And so if you're, I got to tell you, because a lot of the courses that look at expansion, and these courses are very popular right now, and people are jumping all over them. They look at expansion, but they're not looking at expansion within the context of the overall medical functionality of the patient. Yes, we can expand people and make them look better. I get that. That's cool. But let's take it to the highest level. If you're gonna spend the time to expand somebody, let's do it to the point where we really can measure that this is improving their function, it's improving their breathing, it's improving their airway, and not
Right,
just expand them and tip teeth to make things work. And that
right,
requires a little bit more than just a weekend course. This takes effort, folks, and but it's effort that is well worth it. And there's a lot of pieces involved that you need to put together, but it's very doable. We made it through
Yeah.
dental school. We can make it through this much easier, and it's very, very exciting because you can put it into action right away. You can start to become a higher level thinker of aesthetic dentistry when you understand the why as to the problem you're facing. Look, we've got worn teeth, and so diagnosis, bruxism. Uh, really? Why?
Right.
Why is there bruxism? So whenever you come up with a diagnosis for your aesthetic problem that you're facing, you want to treat, I want you to ask yourself why. Well, we've got crowded teeth. Why? We have a cant to the occlusal plane. Why? And if you force yourself to do that, I think you can take it to another level. And the thing that blows my mind, Mark, is that we now can answer that second depth level why question.
With
Unbelievable.
confidence, with an evidence-based approach, data-driven
It's
approach
amazing.
that's much more sophisticated,
Yep.
that is much more supported by the medical and more the dental and more importantly the medical literature.
Yep.
So we're definitely taking a very data. This is not like a fad that's going to fade. In fact, I believe eventually dentistry, dental education will eventually catch on, and this is what they'll be teaching. So the role of the dentist will be very different and go beyond just extracting, placing implants. I think there's a place for that. And then you just button up, a couple things is that um, when you really understand that what you could do for the patient and it does a number of things. I think number one, it fosters what I think is really important in addressing what a lot of specialists get upset about, whether you're an endodontist, an orthodontist, a periodontist, or an oral surgeon, is that the general dentist has been forced to do more and more, taking a lot of CE where they're actually getting ahead of their skis and doing more of the treatment that the specialist should be doing. But
Mm-hmm.
they're keeping it in-house because they're getting all the patients, right? And then
Mm-hmm.
the specialists, how did they get their patients? By referral. So I'm going to say I'm going to support my specialty team and I'm going to make sure they're busy doing what they need to do, what they're trained to do, what they want to do, which is the surgery and those procedures, but it's going to be more targeted with an airway focus. So they're going to get more referrals that are quality referrals in an interdisciplinary approach, where the airway focused dentist is the quarterback, but they're actually working in an integrated fashion with the entire team to do what the specialist can't really do so well. It just doesn't make sense to spend all the time to work up the patient for an airway focused treatment. Um, why would they do that? They should just be doing the procedures as part of a team. And also for the C physician, it's going to be exciting for them because the C physician that we need to work with is going to get more referrals from the dentist that is sending the patients that need to see the C physician first.
Yeah.
So you have this in the ENT. So
Yep.
when I send them to the ENT, it's a very targeted, precise referral that we're on the same page. So we're not talking about the general or restorative dentist doing all this treatment in-house and they're doing, no, we're talking about an interdisciplinary approach. We're working with everybody. I can't do my treatment without a really good periodontist that understands this, without a really good orthodontic surgeon, without really good orthodontic support. And I could stick to the areas that I really understand for the team as the glue, if you will. And the patient in the end is grateful.
Yep.
They're not being overtreated. And they love that they have an interdisciplinary team. And that's one of the things that a lot of patients are frustrated with in medicine is that the cardiologist doesn't talk to the urologist, it doesn't talk to the endocrinologist, it
So
doesn't talk
true.
to the
Yeah.
primary. No one talks to each other because everyone's siloed. That needs to change as well. So what we're talking about is really the future in healthcare that, as Sachin Jain, medical professor at Stanford, said, it is time for the medical professional and the dental professional to break down the silos and start working together. And I think that's the way we'll end this segment, that we can go on and continue. And hopefully we made the point and we can move to our learning moment that really underscores everything that we just talked about. And if
Hmm.
you could share that learning moment
Yeah,
that kind of puts a
I
capstone on everything.
I will, and I'm just before I do, I'm going to say that my approach to dentistry before I became airway trained was very, I thought, as sophisticated as you could get. I looked at what we call the diagnostic diamond. You can hear these four aspects of diagnosis, of risk assessment, of treatment, starting with aesthetics and function, biomechanics, and then periodontics. You know, these four corners of the pyramid. And now I know that all four of those corners are completely and absolutely impacted by airway.
Yep.
Absolutely.
Yep.
And, you know, it's not the same anymore. I still worry about those four things. Ultimately, they're all going to be treated, but now I know why they ended up becoming a problem in the first place. And no one would think that. No one would think that a gingival issue has a connection to airway until they know.
Right.
It's so cool. Anyway, so with
No,
that,
but no, but let me just add to that. If you remember, I think you came to one of my early courses. Honestly, I think it's got to be close to 15 years ago.
yeah,
You came to one of them and you listened to it. And at the time, I was talking about Brian Palmer's his concepts on function, and this is like early on. And I think you, like many in the audience at the time, were like intrigued and you kind of got, oh yeah, I understand that. But then you went back and doing dentistry maybe bugged you a little bit at some level, but you kept on doing what you were doing. And I think I see that as a failure on my part early on, not understanding how really to connect and teach this stuff in a way that's meaningful on Monday, which we're doing now. So I've learned a lot,
I agree.
but you're like early adopter going way back when, but now in retrospect, you see that information from say 15 years ago now, put it in this perspective. Because I remember when you approached me a few years ago and you say, hey, do you have a recording of the AMR? Will you see that? I want to really get more into. I'm understanding this, and I said, let's do something better. Let's do a course, and we did. And I think, like you said, because you're such a good teacher, one of the things that you were able to help me in is this is mind blowing, Mark. This is great. It's stressful, but it's great. I think we could organize the material better to connect earlier on with the providers so on Monday they could start translating it. And I
Mhm.
think we've worked through and we're continuing to work through to make it better for the average provider that's curious that now, okay, I get it. And I think this is why I'm excited in working with you as someone that has been there, that knows with your training all these sophisticated protocols, but now with a different lens that is putting our curriculum really where we're, I think, teaching better than anybody
Yeah,
because we're
I
actually
agree.
addressing what it is. And it's not a weekend course that's widget driven. It's about diagnosis, being a doctor first, but being able to connect with the patient in the way that they're hungry for.
Yeah.
But anyway, that's we can go on with that.
You're absolutely right. And I think once people figure this out and they understand that the 4 points of that diagnostic diamond have another level of understanding, we're going to see those same doctors looking for the answer are going to find us and are going to then elevate their practices. And I
And
wanted to
they'll become
just,
the future teachers. I
uh,
mean, that's what we want,
no
right?
doubt, no doubt.
Because we're gonna move aside, but they're gonna be part of
Yeah,
the the legacy. Which we
I,
need to do is we need to get seasoned dentists that are in mid-career, probably. Maybe it could be early, But
Hmm.
I think mid-career, because you've made enough mistakes to really understand. When you're early career, you don't know what you don't know, and you've got a lot of information, but you haven't
Yeah.
failed enough with your outcomes. So mid-career, you've got the basics down, but now you can move into really understanding and then eventually teaching this stuff in a meaningful way, the way we teach it here, right? And that's what we want to do.
My learning moment. So one of my course participants told me she was very excited because finally she's learned Invisalign. And I said, oh, tell me more about that. She's, oh, I have 15 cases started in less than 1 month. And I said, what exactly are you treating? And she looked at me kind of, with some mystery, like, what do you mean, what am I treating? They've got crooked teeth. I'm treating crowding. And I said, how are you treating it? She goes, well, I have a mentor and he's telling me how to do it. And I said, well, are you doing a lot of this IPR type stuff? She goes, of course. And I've got these cases started and it's just so excited. And I asked her one question. Why do they have crooked teeth? Why do they have crowding? And her answer was simply, they were born that way. And that was the end of it. And I said, is your mentor teaching you why teeth get crowded? What exactly is happening? What are you doing to the rest of the system if you're retracting teeth? Because that might be important, don't you think, based on space for the tongue and airway, etc. She goes, my mentor is the mentor for many hundreds, if not thousands, of Invisalign users, and that's never mentioned. And I said, wow, got it. And so really occurred to me, Mark, that this is, I mean, I don't want to be negative towards it, but I definitely want to say at this point, get it on record, that if you are performing clear aligner orthodontics as a general dentist or maybe even as an orthodontist, and you don't understand exactly what you're doing to the airway when you're treating the patient or what underlying condition exists before you start, I think you could be in trouble. And I think that you need to be really cautious about this. And so that's my learning moment.
Yeah, I agree. It's an example of, and this is the scary part, of getting better at doing the wrong thing.
Mm,
And that's kind of a powerful statement if you sit on it and think about it. And it might even sound arrogant unless you
mm,
really understand. And I always say that if you look at the clear aligner industry, if you get into from the market, the SOM, the SAM, if you look at what these uh, private equity gets into and how they analyze an industry and very sophisticated. Globally, it's in the billions and billions of dollars.
oh, yeah.
Clear aligners
Of
that's
course.
in under the heading of cosmetic, right?
Right.
Kind of like Botox. That I'm saying, think about this. There's this multi-billion dollar global industry. And
Yeah.
there's so many companies that have jumped in. Invisalign was the first, but so many companies, Dentsply's gotten into it. Yeah, multiple companies have gone into the clear aligner industry because they're looking at it and they're going, wow, there's a lot of money to be made here. I say it's an industry that's in the billions and billions of dollars doing the wrong thing.
I agree.
And think about to understand that largely, to understand that, think about our species. This is very well documented. We
Hmm.
just didn't have dental crowding a thousand years ago. By
Nope.
and large, the anthropologists have done digs going back tens of thousands of years. But 4,000 years ago, 10,000 years ago, 500 years ago, that there was in populations all over the world, our species just did not have caries and dental crowding. And it wasn't because of a lack of orthodontics. It was that we just had facial skeletons that weren't compensated by the environment,
Right.
how we born, all the things that we talk about. So when you start really thinking about it, wow, the brain explodes,
Yeah.
is that, and patients understand that,
Yeah.
even 50 years ago, orthodontics was not as prevalent as it is now. And now the general dentist got into these clear aligner. So we've kind of done the wrong thing. The learning moment is interesting. And the hard part for us as educators is talking to other providers that are meaning well. And it's hard to give an elevator speech as to not to say that they're wrong, but that they're over treating the wrong problem, because that it gets you really defensive,
That's so
right?
true.
And so we don't want to offend anybody, but when you really understand the import of what the problem is, it's dental crowding is a finding. Teeth do
Right.
not get crowded. It's not a genetic condition that dad had. It's because there wasn't enough bone. There wasn't enough facial growth. And we're seeing that more and more now.
No wonder they sell more retainers than anybody, too. All these companies. It's just, it's all about the retainers, 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 refinements and retainers, refinements and retainers. And it's amazing how many patients have had multiple tries at clear aligners. Think about it, docs. You're listening to this. How many of your patients have Invisalign that have had it before? Just because the lower teeth got a little crowded, just because a few things moved, and so they are going through it again. I mean, it's like almost every patient I know that I've had that's had Invisalign has had it done more than once, or Invisalign or any clear aligner company. It doesn't matter. The point is that stability. Trying to achieve stability by simply straightening teeth, I think is not it's not an endpoint in treatment, because it doesn't address the underlying causes of the crowding in the first place.
Yeah, it's not understood. Let's give some evidence to also to give this. If you're an orthodontist, think about this. Ed Angle, when Ed Angle came up with Angle's classification
Right.
1, 2, and 3,
Yep.
um, Robert Corcini, who wrote the book on this, Anthropology Explaining Malocclusion, there was no such thing back 500 years ago, 1,000 years ago. Everybody was what would be called a class one occlusion. And what he did is he jumped in when the compensation was great enough to where you can put uh, uh, dental arches into one of three buckets: class one, class two, class three.
Yep.
And in fact, the more recent one was anterior crowding. That was another diagnosis that was added later after Angle came up with a class one, class two, class three. And so uh, anthropologically, we just didn't have that in the past. So
Right.
it's a relatively recent time in an evolutionary time clock in within the last nanosecond. This has really been just like
Right.
obesity, just like type 2 diabetes, just like cardiovascular disease, just like autism, just like all these medical conditions that were very low incidence or rare even 50 years ago that are
ADHD.
now increasing. So
Yep.
that's in the same bucket. And so when you start
Absolutely.
really understanding the ramifications, cancer incidence,
Yep.
and it's not because we're living longer, it's our environment. That's really what we talk about in the airway mini residence. And when you realize that in good conscience, you go, wow, as a healthcare provider, I should really be digging in deeper and not treating what we in airway focused dentistry call a finding,
Right.
because teeth that are crooked is not a problem to be fixed by itself in isolation. It's
Agreed.
part of the solution for sure after you've dealt with the upstream problem. And so maybe we can end on that, Richard. I think it was,
Awesome.
uh, 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 maybe the audience, the listener might get more confused by what we just talked about or get more upset. But in any case, I think that if you really are compelled and curious, maybe consider taking the Airway Mini residency that we're going to be giving in
Hey,
whatever month or
Mark,
so.
let me tell them that at Stevenson Dental Solutions we have an airway mini residency. It starts on January 16th, 17, 18, 2026. We're going to run two of them a year for now. We may have to run them every month by the time this gets out, because this is it, guys. In 40 years of practicing dentistry, I can tell you it, into the depths of my soul and everything I know, I've read, I've written, everything. you've absolutely got to make airway a part of your understanding of what we can do as dentists. It'll change your life, and it's incumbent on us. I mean, like Mark said, this will be in dental education. You give them time; it's going to get there. When Dr. Cruz, when his book gets published next year, 2026, it is going to disrupt the environment of learning, of education so much. It just it cannot be ignored any further.
And
So
just the only question is, are you going to be an early adopter or a laggard,
yeah,
right?
that's right.
And just to make it clear, this podcast
Mm.
is not about the Airway mini lessons. It's not about getting an advertisement for you to come and take the course.
Well,
It's
no,
busy. It's a
I
busy
agree.
course.
I
We may
agree.
not have room, but it's basically to get this message out for us to start talking about.
Well, I know. I just, Mark, if you're listening, you're a dentist, you're probably confused. I mean, maybe you're a graduate or you're a clinical instructor or a mentor from a major company or you're a teaching center. Maybe you're on a faculty of a teaching center that has done extensive, beautiful courses in understanding aesthetics, function, biomechanics, and periodontics, but you're missing out on this element that you don't quite understand called airway. There are solutions, and I'm just saying, find a solution. Come to our course, great. If you want our course, or find another one, good luck. I mean, it's just kind of hard to find one that isn't widget based, and I care enough about my colleagues to know that this is just it's it's an imperative. You've got to get trained.
And whether you're a general dentist or a specialist, every specialty
Absolutely.
pretty much in dentistry has a context of airway focus. I don't care what
Absolutely.
specialty you're in.
Yep.
When you have an airway focus, what you're doing as a specialist will be different. It
Absolutely.
actually will be better. And
Yep.
and and lastly, more rewarding. I could tell you, my team will tell you, it's very different when someone comes to you and saying, "You changed our family, you changed my life. I'm living a better life," versus those are beautiful veneers. I like that full mouth rehab. That's all great, but it's a different conversation when you're saying, I just am a better version of myself. I get along with my family better. I'm not so cranky. My physician's telling me that my blood work has improved. I'm just sleeping better. I mean, that's really a lot more rewarding. So I'll leave it at that. Thanks, Richard.
Excellent.
I'll
Thank you,
I'll
Mark.
look forward to our next podcast,
Me
and
too.
we'll talk soon. Take care.
Okay, buddy.
Yeah, I'll see you.
Take care.
Bye bye.
Thanks.